Good afternoon, everyone. Thank you for joining PHCA for today's webinar, Recognizing Pain in People with Dementia. I'm Wendy Johnson with the Pennsylvania Healthcare Association. PHCA offers monthly webinars to members to receive updates from department staff on regulations, learn from industry experts on current trends and practices, and to gain a better understanding of practical application tools to equip you so that you may continue to provide the highest level of quality care possible. Before we begin, I have a few housekeeping items to cover. This webinar is being recorded and will be made available on the PHCA website later today. The webinar has been approved for 1 continuing education credit for PHCA member nursing home, assisted living, and personal care home administrators. Certificates will be emailed tomorrow, and please note that effective April 1st, I am required to upload the credits to the NAB registry. So hopefully you have all registered for this free service and have provided us with your unique NAB registry number. Following the webinar, I'll be sending a link to a quick survey. Please complete this survey, and if you are participating in a group setting, have each participant also complete the survey. Your feedback is important to us and our speaker. All attendees will be in listen-only mode. However, throughout the presentation, please feel free to submit questions using your questions pane on the right hand of your screen, and our presenter will address them at the end of the presentation. Now for today's webinar. Today's webinar is being presented by Dr. Cathy Ciolek, President of Living Well with Dementia. In people with dementia, pain is believed to be under-recognized and undertreated. The brain changes associated with various types of dementia are believed to have an impact on pain expressions. Many behavioral expressions that interfere with care and a person's well-being may be related to pain, but may be misdiagnosed by symptoms of dementia. There are several tools that can be used to help identify if pain is a root cause, so interventions can be initiated. Non-medication and pharmacological guidelines exist to address different pain types and improve quality of life across the care settings. By participating in this webinar, you will be able to summarize how dementia impacts pain perception and expression, identify tools that can be used to assess and document pain in people's dementia, and lastly, utilize professional guidelines for treating pain with non-pharmacological approaches and medication management. I'll now turn the webinar over to Cathy.
Great, thank you so much, Wendy. As she said, my name is Cathy Ciolek. I'm a physical therapist by training and am the owner of Living Well with Dementia. The objectives Wendy just read in the introduction, so I won't repeat them. But I'm really glad to see so many people are here to get a better understanding of measuring and assessing pain in people who have some challenges in communicating their needs with us. I'm going to start with the CMS Quality Measures for long-term care facilities. There are both long-term and short-stay measures that exist for pain. And the quality measures that will be reported in your 5-star ratings include the percentage who report moderate to severe pain. The Resident Assessment Instrument User's Manual instructs the assessor to attempt a pain interview for any people who have at least the ability to be sometimes understood. And that's really where we sometimes get into a challenge, particularly in long-term care in people with dementia. So this population may sometimes be understood, but not always. And so we have to at least try to interview them and get a pain rating of some type to be able to score it on the MDS. But it's not necessarily consistent in information that is necessarily accurate or consistent. And so it kind of gives us an inaccurate report, perhaps. So when we look at that self-reported moderate to severe pain, it can trigger in 2 areas, either people who report daily pain with at least 1 episode of moderate to severe pain, but also in people who report very severe or horrible pain of any frequency. And again, people would be excluded as people who don't report any pain, or if there is one or more items on the MDS that was not completed. Again, what is pain? And the challenge with moderate to severe when we ask people to scale it is pain is subjective. So it's really whatever the person says it is and exists whenever he or she says it does. And I put an asterisk by that because in cognitively intact or healthy-ish normal people, we can and should understand that how they express their pain is generally considered to be the most accurate response. However, in people with dementia, they may either not be able to verbalize it, or we'll talk about the brain changes that may alter their understanding of what's going on in their body. And so they may not be able to communicate it effectively. But we do know that pain in any older adult can cause suffering and issues with inactivity, social withdrawal, and depression. And it also interferes in the short stay clientele with rehab outcomes and functional decline. We know that pain medication should typically be regularly dosed when we understand that pain exists, and there may be such occurrence for PRN or breakthrough pain. So on the MDS, this is the category where the pain assessment interview should take place, and I'll point out two areas. One is the presence of pain. So if you're asking somebody, have you had any pain or hurting at any time in the last 5 days? So no, you're going to skip ahead through this entire section. Or if it's yes, you'll continue on through the questions of frequency, its effect on function. But the way they ask you to interview them is to use the numeric pain rating scale, which I'll show you in a minute. It is a 0 to 10 scale. It is really the gold standard. Or a verbal descriptor, so that mild, moderate, severe, very severe, or unable to answer. And that's where you get the MDS quality measure data from. So in the MDS, when we're assessing pain, the numeric rating scale, as I said, is really considered the gold standard for cognitively intact adults. And there is some data that shows even in early stage people with dementia, the numeric rating scale may be an accurate measure. People are fairly used to a 0 to 10 scale, 10 being the worst you can imagine. You can use the lines, it can be a visual analog scale. And this is just an example of what that looks like. In assisted living facilities, I looked into the Pennsylvania regulations to be sure I was adequately addressing them. And there's only one place I could really find that they address pain, and that's under the Specialist Cognitive Support Services item under the regulations in 2800.4. And they require that in places with cognitive support services that you offer pain management and person-centered care. And I found them, it was interesting that they were linked because I do think there's a lot to do with both, but they are kind of separate and unique entities. Person-centered care is really just trying to make sure that person is the center of all decision making and focus, and things are clearly not done for staff convenience. And pain management kind of being unique and separate. The personal care regulations, I couldn't really find any link to pain, but just knowing that you're still expected to help people function as best as possible. Really, in any of these three settings, you should be doing pain assessment for people who are showing any of the possible symptoms. So what is pain? So I go to my standard Merriam-Webster. She defined pain as a localized physical suffering associated with a noxious stimulus. And really, so, something, it can be something from like a bee sting up through a bug bite. Both, one is kind of more of an irritant than a pain, but they're typically a physical sensation and is also associated with acute or mental emotional distress. So we'll talk about the different types of pain, but there is physical and or psychological pain. They may overlap as well. Again, we talked about pain is subjective. What I consider to be a pain level for me is unique to me. It doesn't necessarily translate into the same level. And that really kind of gets into when we'll talk about healthcare professionals and understanding people's pain. We consistently underrate pain in other people. And so really making sure as we can get an accurate as descriptive as possible from the person who has pain. There are also cultural factors, and we won't really deep dive into them too much, but just know that how any society or even subset of society addresses pain is fairly unique, and there are cultural impacts. You know, if you think about childbirth as an example, it is a very medicalized procedure for the most part here in the United States, with medications delivered, and a certain length of stay is fairly typical. But in other societies, it is much more natural. It is typically still recognized as having some level of pain or discomfort, but certainly not to the extent of other societies. And so recognizing that those symptoms are somewhat culturally identified is another key. And just if you're working with a population of a subset of a different culture, that their pain expressions may not look as much as what you're familiar with. So there are a couple different components or descriptors of pain. Sensory or nociceptive pain is what we're most used to. It is the pain that you feel to a potentially damaging stimuli. So it is like when you receive a cut or a bee sting. It is associated with post-op pain. So in your short stay residence, it would be anyone who's come from a surgical procedure, but also from things like cuts and bruises, but also some internal factors like arthritis or degenerative joint disease. These are what when we talk about pain, most of society considers nociceptive pain to be what they think of first. And in other areas, there's neuropathic pain. And neuropathic pain is actually when there is a problem specific to a piece of the nervous system. So to the nerve itself, into the spinal cord or brain. So you see more issues with neuropathic pain in people who've had stroke, which is also associated with multi-infarct dementia, so another subset of the dementia population. But also in things like peripheral neuropathy, which you'll see in people who have diabetes, or in complex regional pain syndrome, where we see some symptomologies of pain that seem to be not in the level of to a soft tissue injury itself, but from actual nerve damage to the joint. And then as we talked about, there is psychological pain. A lot of what we understand from psychological pain, is related to things of attention to the pain. So sometimes when people have even a nociceptive or a body pain, when you're distracted, you may not have as high a pain reading, right? So there is some psychological interpretation of whatever we're feeling. And when you can get your mind on something else, you can kind of maybe turn down the signals from the body a little bit. People who are having issues with anxiety can certainly rev up and focus pain till it becomes much more of an overwhelming, not just then the physical, but also the psychological piece. And there are issues with learned pain or pain from memory, which is associated typically with a traumatic type experience. And so there may be issues of triggers to a psychological pain of somebody who has had a traumatic event. What we do see this a lot of times is in veterans who have been at war. And so we see some of the psychological pain that they may have as well. So sometimes word choices in what someone who can describe their pain is really important. When we look at that, again, that sensory nociceptive pain, it is more typically localized to where what we call a lesion or the insult occurred. So if you're cut, you don't feel pain in your whole arm, you just feel it where the cut is. It also could be aching or a throbbing. Those are typical muscular type pain. So if you've had a workout and you overused your muscles, those may be the symptoms that you find. Or sometimes can just be annoying, like people want to rub that area because it's very localized to that area. Other times we have issues with the neuropathic. The words we often hear describing that are more of a burning or an electric, something's tingling is more associated with a neuropathy, but also a shooting or stabbing type pain can be associated if you've ever had an acute episode of low back pain. The shooting or stabbing pain is typically where you'll follow a nerve pattern where there is some irritation to a nerve root. So when we look at pain in cognitively intact older adults, so these are people who have just the normal process of aging going on. And we know that the data on that has been that it is underrecognized and underreported in just typical older adults. Whether there's a question of stoicism, of particularly this generation, as the baby boomers are aging and the generation that preceded it, right? You kind of had pain and you dealt with it. Wasn't something necessarily that people would complain about as much, or whether it's just, again, whether it's a cultural impact. But we do know as many as 50% of older adults report pain of some kind. So if you just picked, 10 people off the street who are over the age of, say, let's 70, probably half of them have some form of discomfort or pain. And it's believed that as many as 83% of those people who live in a skilled nursing facility have at least one current pain problem. So the assumption is almost should be you have a pretty good chance of having someone in front of you who has pain. And pretty recent data that came out just earlier this year is, as I mentioned earlier, healthcare professionals consistently underestimate pain compared to a patient's self-report. So my interpretation of your behavior gives me an attempt to guess at how bad your pain is. And so we tend to underestimate and then perhaps undertreat. When we look at pain specifically for people with dementia, it's very hard to get that reading, and we talked about earlier, but there was a fairly recent systematic review, which is, again, looking at lots of different independent studies and trying to see if we can pull that information. And they estimated between 46 and 56% of people with dementia have pain. And it was differentiated a little bit. We'll look at some of the different disease types, dementia types. But they based this on some of these other studies previous to this and these ones that have come out since. So again, another study that looked at people with hip and pelvic fracture. So if you've ever fractured a bone, you know what the level of pain is like associated with that injury. And they found in the systematic review that people who had these types of fractures, if they had dementia, they were 50% less likely to be receiving pain medication than cognitively intact older adults. So we already know older adults are undertreated as a group. And now if you make it even worse, they're getting, if you have dementia, you have about half as likely a chance to be getting any medication at all. Another one that was really looking at oral health. And so we know the challenges of providing care for people who have early to moderate stages of dementia and certainly into older, later stages, that their oral health is compromised. It's very hard to get a toothbrush in, or they may be doing it themselves and you don't know how good they're really getting all the areas. And in this study that they found, when they looked at all these studies combined, that they were able to determine that people with dementia had worse oral health overall, and that the majority of them had likely oral pain that was not being treated. A different study that was a lot done earlier by Cohen Mansfield, she found that of about 60% of people with dementia were likely to be having oral pain by dental assessment. And then in another one, another study looked at nursing home residents with dementia, and just overall, they had the same number of other conditions such as arthritis and heart failure and diabetes, and they were consistently given less pain medication than their equivalent people who were cognitively intact. So does it differ by types of dementia? And one of the challenges is we don't have great diagnostics, although it's certainly improving in determining what type of dementia someone may have. And that knowing that dementia is really what we consider an umbrella term. So it includes issues like Alzheimer's or vascular dementia or frontotemporal. And then you have these other affiliated ones like dementia with Lewy body and Parkinson's disease-based dementia and progressive supranuclear palsy. But the thing that is fairly consistent amongst all of them is there is some associated decline in memory, loss of thinking skills, and disorientation, along with impaired judgment and problem solving. And it has to be severe enough to impact their daily activities. But each of these types involves different areas of the brain, different types of insults or lesions, and each individual is, of course, unique and presents slightly different. But in the systematic review by Van Kooten, they were really able to pull some numbers, and you'll see it actually is pretty close to 45 to 60, 56% across the different types. They found that people who had Alzheimer's type, of course, that's more associated with executive function challenges and memory and judgment and navigation. They had the lowest percentage at about 46% of the population showed signs of pain on different pain measure scales. Vascular was higher, which again makes sense because that's an insult to the neurologic system. So the neuropathic type pain is going to be more common here at 56%. And then they were able to look at people with mixed dementia, which is most often a mix of Alzheimer's and vascular type. And they were, obviously that number is somewhere between the two. The studies were not able to be combined enough in people with Lewy body dementia or frontotemporal, but recognizing that each of those, frontotemporal would be anticipated, at least in my mind, to perhaps be the less likely, because except that their risk-taking seems to go up. And so, they may put themselves into situations where they cause pain to occur more often. Similarly with Lewy body, those gait changes may put them at higher risk for falls. So again, looking at some of the brain changes that we know take place in people with dementia, it has a high impact on what we call the limbic system. So without getting into too much detail, what you should really know, and particularly in the Alzheimer's type, the limbic system is made up of a bunch of these structures. The amygdala, which is the emotional center of the brain, it's where we store and recognize different emotions, as well as the hippocampus. You can see on the video or on the picture just below it. It's where we make new memories based on past experiences. So sometimes we're reformulating our memories and they can get a little bit more mixed up, perhaps, in this area. And so when we see challenges on the limbic system, we anticipate that there could be associated changes in mood regulation, which is why we see a lot of issues with anxiety and depression, but also perhaps in a response that isn't what we would anticipate from a normal stimulus. So when we see an overreaction by our measure, that, I just touched them, it wasn't deep, but that change in the brain system can cause an overreaction. And so they're feeling it more than we think they do. When we look at pain specific to Alzheimer's, again, those limbic system changes can cause what we call hyperalgia or allodynia. So that's a painful response to a non-painful stimuli. So that's where something like light touch, just holding someone's hand, stroking their skin, can be felt to be a painful stimulus. It is not, it shouldn't be painful, but it is. And so the data is really kind of looking into, are we really seeing some issues in behavioral response to activities of daily living, like dressing, helping them put their shirt on, moving their shoulder, that may be painful, bathing, the water temperature where you or I would not necessarily feel that it's too hot, may be perceived as too hot. So the allodynia type symptoms makes sense when you look at the brain changes. Hyperalgesia is when you have a pain stimulus, but it creates a increased sensitivity to it. So whereas you might have been able to live with it for a long time, now it becomes much more significant, even though the condition itself isn't worse. And again, that is associated with some of the brain changes we see in dementia. So when we're looking at the impact on behavioral expressions, another review looked by Van Dalen found an association between pain and anxiety, agitation and aggression, hallucinations and delusions, disruptive behavior, wandering, and challenges with personal care. So the link just makes sense when you can go back and look at the brain changes we talked about. So the question I have for facilities who have people who are showing anxiety or agitation. How many people are being treated for these symptoms of anxiety or even psychosis, because we see that with hallucinations and delusions and disruptive behaviors, when they're really having pain. And if we have really not delved deep into a good person-centered assessment to see if pain could be causing these behaviors. Similarly, there's a relationship with depression. A study out of Norway, and Norway seems to be fairly more advanced than the US in a lot of levels at addressing this issue in people with dementia. They have found a correlation between the pain levels and depression. And so when they were able to reduce pain with medication, they also saw less depression symptoms, and in fact were able to decrease their antidepressant medication. And the systematic review found the odds ratio of pain and depression to be 1.84. And what that means is if you have pain, you are 1.84 times likely to also have depression. And so here the question becomes, how many people are being treated for depression when what they really have is pain? And so when we look at, for depression particularly, is the pain causing depression? And thus we see signs like weight loss or disengagement, and we're treating it with antidepressants. So if we're here, if we had treated the pain instead, we wouldn't proceed on to the depression and the need for antidepressants. We could avoid perhaps psych referrals and secondary effects of the antidepressant medications that can impact the well-being of the person with dementia. It's also financially in the best interest of facilities to be able to maintain weight, right? In skilled level nursing facilities, triggering on a weight loss involves a whole lot more work for the staff. And so if we're seeing weight loss, if we could address it, is the weight loss because they're having oral pain? Is the weight loss because they're depressed? So really using a root cause analysis to go down into, have we looked at all of these possible triggers before kind of treating the side effects of the problem. Additionally, in Norway, excuse me, they did a study of people with dementia using actigraphy. And that's where you wear a device, typically on your arm, that's going to measure your time sleeping. It is able to tell by levels of sleep quality, how fast you fall asleep, how much you're moving, so what stage of sleep of the various stages, how long you're in rapid eye movement stage. And they found that when they treated people for pain, they had improved sleep efficiency, which is the total time spent asleep versus the time spent in bed. So meaning that they're having a better quality sleep overall. Also in sleep onset latency, which is the transition time from full wakefulness to sleep. So you're less likely to be putting them to bed and having them get back up. And so they can go to sleep sooner. But also in early morning awakening. So they're going to sleep longer and perhaps sleep through to more normal length cycles. And again, that can have impacts on staffing. So if your residents are sleeping better, your staffing patterns at night financially may be able to not, you may not need as many staff on board, or you may not have as many people who are waking other people up, or you may not even need, I have some facilities I know that are talking about activities people at night to address people who are awake. And so all of those pieces, if we can impact people, how many people would sleep better if we adequately treated their pain? Again, I look at falls often is what I get called in for. And so if we're seeing falls, particularly in the night, what is waking them up, and can we, is it pain that could be a side effect? So when we're looking at sleep, is it disrupting their sleep pattern and causing behavioral expressions? So the Empira group, which is a conglomerate of independent nursing facilities out in Minnesota, I want to say, has done a lot of work on sleep, and they used actigraphy as well to assess people and try to determine what was waking them up. because what they found was that when they could improve people's sleep, they actually had less falls. And so they did a whole lot of interventions in their facility to improve the sleep quality and duration and allow for normal wake and sleep cycles. And so what you see too is if we can address pain, instead of letting it impact their sleep and causing behavioral expressions and a lot of antipsychotic use, we might be able to decrease antipsychotic use at the expense of the medications, the consultations, if we were adequately able to address their pain. So the American Geriatric Society has looked at different areas of how pain appears in people who may not be able to verbalize it. And they really came up with 6 categories. And those are areas of facial expression. And there's some very interesting studies going on looking at tapes and caregiver understanding of facial expressions. And we recognize grimacing pretty typically, but if somebody is frightened or sad, which we know if you were afraid to move because you thought it might cause you pain, or if someone was coming in to do something to you that could cause you pain, you could appear frightened in that response. But they also were able to identify issues with rapid blinking or just tightening of the facial muscles around their eyes. So it's a very tense facial expression. You can also look at verbalizations and we'd say, okay, well, they're making noise, right? But this isn't word choice necessarily, but verbalizations of things like moaning, groaning, but also chanting, repeated phrasing, which we tend to see and staff tend to turn off because it's the same phrasing people use over and over and over all day long, 24/7. But that type of chanting is may actually be a verbalization of pain. The other verbalization we see often is just this help me. I can't tell you the number of times I've been in facilities where there is, say Mrs. Jones, who is sitting and crying out, help me, help me, help me. And the staff have really become immune to it. They don't know what to do. They think it's just like almost like an aphasia, or like those are the only words she knows, but it really could be asking a seeking of help to address a problem. And when if you ask them about pain, they won't necessarily be able to say that I'm having pain, but clearly they're in distress and discomfort. The other area we can look at is in body movements. So again, if I know when you move my shoulder to put my shirt on, it's going to hurt, I'm going to hold my arm rigid so you don't do that. Again, that's not a high cognitive thought level, right? It's a learned behavior to a painful movement. So these tense body postures, which we often see expressed in ADLs, are really potentially another sign of pain. But also things like pacing, fidgeting. Fidgeting can also be something from boredom, but rocking specifically is a soothing motion. And if you had joint pain, particularly around, like, say, your hips, that rocking motion may be able to relieve it. And think about your person who is perhaps less mobile and sitting a majority of the time, maybe not able to reposition themselves well. So the pain may not necessarily be from an internal issue like an arthritis, but just from sitting without moving. And so if you've sat during this talk so far today and not really kind of shifted or repositioned yourself, you would be uncomfortable as well. Other issues such as interpersonal interactions. So we see people resisting care or being aggressive or combative. And this usually goes into being classified as a behavioral or psychological symptom of dementia, when it really may not be. It may really be more of a sign that they're afraid, that they are hurting, and they really can't tell you. Also, they can be socially inappropriate. So expressing verbalization of word choices, perhaps, that they may not have used at other times in their life, or self-comforting measures that we would not encourage in polite society, let's just say that, or just a withdrawing. So it's the person who perhaps is not coming out of their room to engage in activities, or perhaps turning down dinner, etc. So it leads to kind of that change in activity patterns. So we talked a little bit about weight loss earlier, and I repeat on here only because we know the side effects of weight loss, let alone the regulatory side of things, of having to go through and do a significant change MDS if you're in skilled nursing. But also if they're not getting the nutrients they need for any kind of healing, if there's a wound, or really not getting enough nutrients they need to be able to function and maintain muscle strength, and good cardiovascular health. So you may see them refusing food. If you've been in pain for any amount of time, you typically find you're not eating as much. It's kind of just a normal pattern because it's just not as appealing or interesting. Eating is also a very social activity. And so we look at the relationship with depression. You can see where cutting back on food is also perhaps a link to depression. What was really interesting for me when I was looking at the literature was in wandering, because it's one of the areas, again, I often get consulted on. But changes in wandering patterns and that pacing piece, but also changes in rest patterns. So somebody who normally slept all night and doesn't, but also somebody who didn't used to nap a lot during the day and suddenly is taking more naps, could be a sign of pain. Also with mental status changes, obviously crying is a sign, or irritability, but also just that distress when you can tell something is wrong. But also a change in mental status or increased confusion can be associated with a new onset of pain. So so prior to opening my business, I worked with the Pennsylvania Restraint Reduction Initiative. And so one of the things we did was be called in when people were having challenges in long-term care facilities. And so over my time with them, we did hundreds of chart reviews, and we would often be called in for somebody who was having a fall or a behavioral expression. Staff had tried everything that they could think of. And we'd look through and we would see documentation that nursing did the assessment that was required. They were constantly asked if they were in pain, and their response was fairly consistently no. And so one of the biggest aha moments for me was, being able to share with people is, so if this person told you that, they had dinner with their mother last night and they were so happy to see her, and that this person's mother has been deceased for some time, you clearly don't believe them, right? They were telling you a memory, they were telling you something, right? That is an inaccurate information. But we assume that somebody who has dementia gives us an accurate response whenever we question them on pain. So when we would do chart reviews, I would see people who, still had significant bruising from a fall. Fortunately, they may not have fractured anything, but I would go in and if you've had a fall in the recent past, you know what it feels like, and it is uncomfortable. I slept on some ice about a year and a half ago and it was probably 6 months before I no longer had some level of pain associated with it. And I was very happy to take my Motrin whenever I needed it. But if I had dementia and couldn't have told you, I wouldn't have been medicated and would have been a lot more grouchy, I would expect. So how do we assess it? We know that the 0 to 10 scale is probably not going to be an accurate response in a good portion of the people who have dementia. So there are several scales that are out there. These, I'm going to show you two, which I think because they have some of the better data on them from some different studies, but there are lots that may be more appropriate for your staff or your clientele. So the first is the PAINAD. It is probably one of the more recognized scales, partially also because it's fairly easy. It is 5 items on a 0 to 2 scale. So how is their breathing? separate from vocalization. So are they just breathing calmly? Are they having some labored? Or are they having more labored and noisy breathing? Now, clearly, if someone is up to Cheyne-Stokes respirations, that's fairly close to a terminal stage. So that's a pretty easy one to identify. But how are we seeing from negative vocalization? So they having none, an occasional moan or groan, or repeated trouble calling out. How are their facial expressions? How is their body language? How is their consolability? Each of these can be scored, and you get essentially a 0 to 10 scale, 10 being the worst and 0 being what we would assume to be pain-free. Now, it's really nice because you think, oh, then I can put the number in that box. It does not, unfortunately, completely translate to a 0 to 10 typical pain scale, but you should recognize that if they are testing at a higher number, it is more likely that they are having pretty significant pain. The other scale that is the PACSLAC, and this started, so the PACSLAC 1 was a 60 item, and the PACSLAC 2, which is shown here, is a 31 item. So it's a little easier, but recognizing that it's really just a checklist. There is no depth scale, so each one is just yes or no. Are you seeing grimacing? Yes or no. A tightened face, other pain expression, eye movement, wincing. But if you look, these categories correspond to the pain, the American Geriatric Society pain areas that we talked about. So facial expressions, verbalizations and vocalizations, body movements, changes in interpersonal interactions, and mental status changes. So they essentially built a scale that addressed the 6 areas that AGS is supporting. And so interestingly enough, and again, why I chose them is they actually have some different dimensions to them, as you could see. So a study by Herr really found that they identified as what they consider to be best practice is actually doing both the PAIN-AD and the PACSLAC to combine them, and that if one might catch some things the other doesn't. And you could track people over time using both types of tools. Neither is hard to do. It is not super time consuming. It does just take, getting used to the components of the scoring. So if we identify that someone does have pain, really what are we looking for? So non-pharmacological management is really anything that's your non-drugs. So things like massage. So recognizing massage can be very helpful. You may also have people with, we talked about the allodynia earlier, so they have more sensitivity to touch. So in some people, massage may be great. In other people, it is not. But also therapeutic touch, again, works for a lot of people. Simply holding someone's hand for a while and being present and engaged with them has great side effects. Other things like hot and cold can be used, very old things. I fall down, I'm going to put ice on it for the first little bit, and then, if things are stiff, you may look at heat. The challenge, again, with these is just making sure that their sensory system can handle it, that you are addressing that it's not going to burn them or be too warm, or leave their skin exposed to too much cold. Movement, we know that movement typically makes people feel better. So if someone is having pain and wants to rock, they have access to a rocking chair if they're really not capable of walking. Can you put them in a glider so that they have some way to self-stimulate and self-calm? But also normal walking. So somebody who has arthritis, sitting for a long period of time is going to increase their discomfort. Usually getting up and moving on a regular basis. And so if you're working with a population who needs more assistance in that, do you have a plan for helping them move more often, even if it's for short pieces of time? And again, as a physical therapist, I felt I really definitely needed to put in a plug for PT. Also, you can look at OT and some other pieces of, they're going to do an assessment. There are things like electrical stimulation or TENS that can be used for some pain relief. Certainly in back pain, the research indicates there may be times to do things like traction. I have successfully done traction and stim on people who have dementia. It is a little more time consuming. It is a little more structured in that I'm going to sit with them the whole time and make sure. In fact, one of the people I was able to do it with also happened to be a person who had dementia who was also a war camp survivor. So there were a whole lot of factors going into how we were going to address her, what she needed. She had mechanical back pain that had to be addressed. But also things I didn't list here, things like activities, engagement. When you're not sitting around thinking about pain all the time, when you're engaged and not bored, it's certainly easier to perhaps not pay attention to something that was causing discomfort otherwise. When you look at the medical standards, according to the American Geriatric Society, and as well the British Geriatric Society, acetaminophen, or the basis of Tylenol, is typically the first line of medication management. We always want to start with a non-opioid medication. You can also look at things topical, like a lidocaine patch, which is again going to be specific to an area that may be having pain, or a topical NSAID, which is like a lot of the creams that can be rubbed on. Somebody who has a neuropathic pain, so the acetaminophen is the first line for what we would consider nociceptive, like those cut pains, those surgery pains, bruising pain. If you have somebody who has neuropathic or neurologic-based pain, gabapentin, which is a Neurontin medicated, these are really where those class of medications tend to address nerve pain better. So knowing what type of pain it is and their history. So if it's somebody who has diabetes and you're giving them acetaminophen, they may not respond because it's not the right kind of pain for the type that they're having, pain medicine. Most of the non-steroidal anti-inflammatories, most of your anti-arthritis-based medications should be used with caution in older adults and people with dementia. And so if you do use them, knowing to start low and go slow is very important. Your physician should be well aware of those prescribing guidelines. The last resort is typically of an opioids type medication. A lot of physicians are appropriately nervous prescribing them these days. There's a lot of attention on medical prescription, but recognizing this is the population that isn't necessarily we're super concerned about addiction or moving on to other types of drugs, drug-seeking behaviors. So really, opioids have shown some great data in people with dementia in addressing their pain and improving their quality of life and well-being. But with any of them, make sure you're looking at all the diagnoses they can have so that you're addressing their pain appropriately. And monitor for side effects. Are you seeing a change that we would expect or not yet? Do we need to try a different medication? These don't have long half-lives, so it's not like you can't be changing them at some point. And when we look at the literature specifically for prescribing for people with dementia, it's not super extensive yet, but it's growing. There was a study that looked at people who have agitation, and they were also treated with an opioid analgesic, and about half showed improvement of their agitation within 4 weeks. And there was another study, which is a little larger, that looked at a stepwise protocol on pain assessment and behavior. And what they found was a reduction in pain, but also an improvement in ADL function. And so for the personal care and assisted living facilities that are particularly out there, SNF cares about this as well. But I know having people be able to sustain some ADL function for as long as possible is really key. So, again, if we're looking and treating appropriately on a stepwise progression, what could be pain, they may be able to stay in your facility longer and function longer at the level of care you provide. And then the most recent study that I'll talk about here was specific to dementia care units. And they found, they did a training education program for their nurses. And so they did, in some facilities, they did just the pain education. So teaching nurses to be more aware of what pain is and what it looks like. And in the other facilities, they did pain education as well as a specific pain protocol based on the American Geriatric Society guidelines. And what they found was there was an improvement in the pain levels, but also in non-pharmacological management in the facilities that had the protocol. So this group was able to not only, it wasn't necessarily showing an increased use of medications, but they were able to relate an improvement in well-being and function in their population. So the take home really is recognizing that people with dementia feel and express pain differently. Part of it is the associated changes that take place in their brain. Part of it is also the piece that impacts their communication. So what I have found is if you look at it as a distress, and do they appear to be in distress, then there's likely a type of pain going on that is inadequately being treated. We know that the pain behavior assessment tools are key to recognizing pain. And so making sure that your facility uses some form of a standardized assessment. Again, I showed you 2 tools. You're welcome to use, there are lots of other ones out there. But having something that we can document changes over time in the same people and make sure that you're addressing their issues. And lastly, that we know pain presents differently. And so what you see as behavioral expressions and things that impact their well-being can improve when we address them appropriately with pain treatment. So those are kind of my key pieces. I love doing this and working with people who have dementia and trying to go in. I kind of feel like I'm a detective a lot of times, trying to see what is missing. So this is how you can reach me. If there's anything that I can do for you, please let me know. You'll see in your attachments, there are a couple slides of references that you can look at as well.
Awesome. Thank you so much, Cathy, for the great information today. At this time, we'll open up the question and answer portion. Please submit any questions using the question box on the right hand of your screen, and we'll just give it a couple minutes. We had really good attendance today. Thank you for joining. And note that while we're waiting, I'll plug our annual convention, which is going to be November 13th to the 15th in King of Prussia at the Valley Forge Casino Resort. And Cathy has submitted some proposals to speak, and we will be slotting her in as appropriate and as we can. So know that you'll also have an opportunity, if you plan to attend the convention, to take in at least one of Cathy's sessions. All right, while we're waiting, don't forget to complete the survey that will be emailed tomorrow morning, and a recording of today's webinar will be made available on the PHCA website, as are all past webinars. Please take time to complete the survey. I'm not seeing any questions, but know that in the follow-up emails, I will attach the slides as well as provide Cathy's contact information. So if you do if you think of anything and need to reach out to her, she'll be happy to answer your questions and be in touch with you. All right, I'm not seeing any questions. So I just want to thank Cathy again for presenting on this important topic, and just want to wish everybody a great remainder to your week. Thank you.